Welcome once again to medical students whom join us in this session of the virtual clinical training. In a previous session we discussed normal breathing sound. Today we will discuss abnormal or added lung sound or breathing sound. Before we go to this, we have to revise the previous lecture. This is normal vesicular breathing sound. Inspiration, expiration. Inspiration 3 times the inspiration. We can hear it all the chest, which is the most normal breathing sound. This is the other normal breathing sound, which is bronchial, tubular. There is a gap between inspiration and expiration. It's the harsh sound. Can be heard normal over trachea or below the clavicle in young and children. But if we hear it over the chest, it's either consolidation or fibrosis. The other normal sound is the bronchovesicular. So vesicular and bronchial is a continuous, is a combination of both normal breathing sound. Here in a posteriorly between the scapulae. First subject today we'll discuss is the crackles or crepitations. Or ralls. Crackles or crepitation or ralls are clicking, rattling, or crackling noises that may be made by one or both lungs of a human with the respiratory or cardiac disease during inhalation. We see in this lecture and previous demonstrations for these sounds, and the student cannot know this sound unless have some experience. So give that the familiar sound you know in your life to make it the problem, and the sound near that the real sound. But really it's not as real as that what happened in the patient, but it is simulation. These sound, crackles, inspiration, they are often heard only with a stethoscope on auscultation, because some sound we can hear in the naked ear. If we hear bilateral or basal or bibasilar crackles, usually use this term in clinical practice. Bilateral crackles refer to the presence of crackles in both lung fields, while basal crackles or basilar crackles apparently originate or near the bases of the lung posteriorly. Bibasal or bibasilar crackle refer to the crackles or ralls or crepitation at the bases of both left and right posteriorly. Crackles are caused by the bobbing. The alveoli is closed before reopened, previously closed. That's why it's during inspiration it will open. The crackles during expiration is collapsed. So during inspiration it will be opened. This sudden opening causes the crackles of the small airways and alveoli, which collapse by fluid, exudate, mucus, or lack of aeration during expiration. The word ralls derived from the French words meaning rattle. Crackles or crepitation classified a number of the classified types. But the most common we will discuss is fine crackles, and coarse crackles or crepitations. Other types, for a time being, no need to know these, the remaining types. You have to know only fine crackles and coarse crackles in this stage of your study. Fine crackles, as we know, you have to know that they use a chest piece, diaphragm, and position in the chest wall anterior posteriorly and maneuver in a sitting positions. What are the characteristics of these crackles? Explosive, high-pitched sound, don't change after coughing or deep breathing. Unlike coarse crackles, we will see it change with the deep breathing. Resemble the sound of dry hair, ruled between the finger close to the ear, dry hair, not wet hair, or sound of wood burning in the fireplace. It can be heard in both phases of respiration, but mainly inspiratory. Early inspiratory and expiratory crackles, hallmarks of chronic bronchitis, while late, which is most common to see in the clinical practice, inspiratory crackles may mean pneumonia, heart failure, or atelectasis. What the mechanism of crackles? Each crackles occur at the particular transpulmonary pressure and represent reopening of the previously closed or collapsed alveoli. Causes of fine crackles, pulmonary fibrosis and pulmonary edema. This is the most common, while other causes, this is rare, can cause pneumonic consolidation, allergic alveolitis, bronchiectasis, cystic fibrosis, chronic bronchitis. While coarse crackles also use a diaphragm and in the chest wall, anterior posterior, and in a sitting position, proper sitting. Characteristic of coarse crackles is a discontinuous, brief, popping lung sound, explosive, lying, gargling quality. They are louder, lower in pitch, and last longer compared to the fine crackles. They have also been described as bubbling sound. Can modified by taking deep breath or by coughing, except in bronchiectasis. Or the crackles appear after coughing, what's called post-tussive, especially in a TB. Characteristics of these coarse crackles can be heard away from the affected area and by holding the stethoscope to the patient's mouth. The mechanism, coarse crackles are thought to be caused by air bubbling through the mucus in the large airways. Causes of the crackles or coarse crackles: chronic obstructive airway disease, pneumonia, lung abscesses, tuberculosis or tuberculous cavity, and bronchiectasis. This is the fine crackles. Inspiratory. Late in inspiration, in the heart failure usually. While this is the coarse crackle, discontinuous. This is a coarse crackles. Next abnormal sound is the sibilant or wheeze. The sibilant or wheeze is what most healthcare professionals refer to the wheezing. They are characterized by high-pitched musical continuous sound. They are caused by narrowing of the airway around the obstruction during inspiration During inspiration, this sound usually during expiration. During inspiration, elasticity of airway will causes them to dilate, which allow the air to flow around this obstruction, either mucus, inflammation, edema, and the airways contracted during exhalation. Airflow increase, causing this turbulence of airflow and this high-pitched musical sound associated with wheezing. Some wheeze are only heard with a stethoscope, but wheeze can often be heard with the naked ear. Wheeze most often is caused by the obstruction of blockage or narrowing of small bronchial tubes in the chest. It can also be caused by obstruction in larger airways or vocal cord. The tone of the wheeze can vary depending on which part of respiratory system is blocked. Narrowing in the upper or lower airway obstruction. Upper respiratory system may make for a coarse wheeze, generally polyphonic, more than one tone. The wheeze with the multiple notes is characteristics of large airway obstruction. Lower obstructions may be more musical. This is what's commonly seen in the bronchial asthma, where a monomorphic wheeze, single note wheeze, is more typical of a small airway obstruction. Wheeze is most obvious when the person is breathing out and exhalation. This is the most commonly seen, but also can be seen in the inhalation. A wheeze may be detected during forced expiration in normal athletic during exercise, or that the forced expiration. Although wheezing is associated with airflow obstruction, the degree of obstruction cannot be reliably predicted by presence or absence of wheeze. Sometimes in a silent chest, severe obstructions, but there is no wheeze. Sometimes we have a high musical sound, but the obstruction and condition is more stable. Sibilant wheeze, or the wheezing of the inspiratory and expiratory. As we said, that the expiratory is the most commonly seen. Also by diaphragm, in the chest wall, anterior, posterior, and in a sitting position. Characteristic of this sibilant sound or wheeze is loud. Sometimes we hear with the naked ear, musical and continuous sound occurring throughout the respiratory cycle. Expiratory period is frequently longer or mainly occurring in the expiration, heard over anterior, posterior, and lateral wall of the chest. Who developed wheezing? I mean, which patient? Anyone, any age, from infant to the elderly adult can develop wheezing. Children and infants more common. Children with asthma often develop wheezing. Wheezing is also quite common in infants. It's estimated that up to 25 to 30% of the infant develop wheezing in their first year of life, while wheezing may be more common in babies because they're small airways. Also, children under 2 years of age are susceptible to a common but easily الو عليكم السلام. هلا دكتور، شلونك؟ الله يعزك، الله يخليك. الحمد لله رب العالمين. استاذ رياض شلونك؟ بس الله تعالى. استاذ